course, the most important milestone is getting started our confirmatory phase 2A trial, phase 2 trial. And essentially we're going to replicate the dosing, which is found safe and showing sustained benefit. We just want to confirm with a higher power exactly what we've already seen, a safe dose and an effective dose in Alzheimer patients, and that's severe Alzheimer patients. That's got to be our highest priority. But in addition, we're going to look for ways of extending out the platform into other indications, first being Fragile X. So we hope to actually get underway a Fragile X study this year. But we will also be open to other indications. I think without going into too many details, we have indications from other laboratories and other clinics that the potential for Bryostatin may be there for other indications. And in our own preclinical models, we've certainly seen that. That could be. So we're going to be open to that. And those clinicians that work with us also, of course, advise us, I'm sure advocacy groups as well. So I give you for an example, we know that both adults and children, when they go through extensive surgery and have had general anesthesia, they often have cognitive deficits after the surgery. We potentially might be able to start helping that by actually treating the patients before the surgery with a Bryostatin approach. So there are a number of situations where we might actually apply in a meaningful clinical way the drug and also other members of the drug platform here. But I guess I would re-emphasize the mechanistic approach that we took. It's quite different from the industry approach. Largely in the industry, there's either licensing in other technologies that others have done, or trying things empirically often with very, what shall I say, modest mechanistic framework background. In this case, we started differently. We started with mechanistic frameworks at the NIH, the Neurologic Institute, where I was a lab chief and director there for many years, and then at the Rockefeller Institute, where I was also scientific director, and I helped manage teams of people where we had amazing positive resources that helped us really look comprehensively at the mechanisms. Then we looked, after the mechanisms emerged, then we looked at how extrinsic factors could be brought in. So intrinsic factors are in the brain of patients who are functioning normally with cognitive tasks and also abnormally. And then that's with intrinsic mechanisms, including those that occur during development, during childhood development. Then we started to develop extrinsic means with drugs that would target those intrinsic mechanisms. In that sense, we think we're essentially taking advantage of what the God-given mechanisms are, what they are there naturally already. For example, the PKCϵ coordinating synaptic growth factors works during development of children to essentially build the networks. And what was amazing and kind of an aha experience was to see that we could re-engage the PKCϵ with our Bryostatin lead at Neurotrope. We could re-engage that mechanism in adult networks, first in preclinical models, and now at least some evidence showing this persistent benefit in severe Alzheimer patients, suggesting that we are re-engaging it now in a totally different, mature context for the synaptic networks. And that approach, I think, gives Neurotrope a lot of confidence in what it's doing because it's based on all that work that preceded it. And it's hard to get the resources for doing that, and that's part of the reason why investment is shy to doing that. But based on my own experience and the teams that I worked with, we had that opportunity. That opportunity came from a whole variety of sources, from the government, from private sector, from advocacy groups, that all contributed to making this happen. But then we had the mechanistic framework within which to develop the drugs. And I think this is what recommends our drugs.